welcome everybody. As Victor mentioned, my name's Brian Link, and we're going to talk today about the emerging use of telehealth in the care of patients with many different diseases, but ultimately try and tailor it a little bit to people with lymphoma. I have many open thoughts before we get into content. Number one, first and foremost, it's important to acknowledge the role that the Lymphoma Research Foundation plays in this weekend's event. The Lymphoma Research Foundation is really an amazing organizational infrastructure that does a great job of connecting those of us who care for patients with lymphoma and for those of us who construct research ideas for those with lymphoma. LRF does a great job of connecting us with patients and loved ones whose lives are most affected by lymphoma. And it's a great way for us to continue to hear from that group and stakeholder, if you will, and keep us on the right path for making sure that the questions we want to ask are relevant to you as a group of lymphoma patients and your loved ones. So kudos to LRF for putting this session on this weekend. You're going to have a lot of different topics today, tomorrow, and Sunday that you're going to get into. This is a little bit of lighter, a little less serious, if you will, but it's an important topic that I was first asked to address a year and a half ago. And that is in your care plan, or in anybody's care plan, telehealth has become a more visible option. And they've asked me to talk about how should telehealth be used in the care of patients with lymphoma. And I'll point out that there are no right and wrong answers. There are a lot of biases. I have a bias. I'm in my 60s, and just as Victor and I were talking, I would much rather be at an in-person session right now somewhere with you, looking you in the face and interacting and having side conversations before and afterward. I've had to make personal adjustments, professional adjustments, as I decide how to use telehealth to interact with my patients. And these answers right now are highly individualized between caregivers, and I mean by that, I mean professional caregivers, physicians, nurses, pharmacists, as well as highly individualized among those of you, patients and family members who are consuming care. So I'm looking forward to sharing some thoughts with you and then hearing your feedback afterwards, because this is an important topic. Okay, so let's talk a little bit about the objectives. We'll talk a little bit about the history of telemedicine, starting from the beginning of the pandemic. And that'll evolve into what have we actually learned about telemedicine now that we've been using it the past 2+ years. And we'll finish with a little bit of the rationale for telemedicine in 2022 and beyond. So it'll start with some biases, and then, as is true with any debated topic, we'll try and evaluate the facts that have accumulated in the past couple of years. And then based on those facts, we'll reevaluate our biases and opinions, looking at the current, as they apply to the current scenario and the near immediate future. I should indicate that on paper, I don't have any conflicts of interest. I have not done research in the use of telemedicine. I have not invested in any telemedicine tools or software. That being said, there's always hidden biases, right? And that I do and have for a long time made a living by having people come into the office to see me in person. Okay, so let's go back to the fundamental aspect of COVID-19 in lymphoma patients. And here was a slide that I literally put together for a lymphoma educational LRF educational forum in May of 21. So now a year and a half ago. And a year and a half ago, I said, well, there'd been substantial progress in suppressing the pandemic in the United States. Case rates were down at that time, but about 35,000 documented cases daily. Hospitalization and ICU utilization was down. Death rates were down, but there were still about 600 patients documented daily. Okay, so now if we look at that exact same paragraph today, well, it's true, there's substantial progress on suppressing the pandemic in the United States. Case rates, maybe they're down, but I checked, New York Times says there are about 35,000 documented cases daily. Hospitalization and ICU utilization are down from a year and a half ago. I think that's true. And the good news is death rates really are down. With that same 35,000 documented cases daily that we had in May of 21, we're now down to under 400 COVID-related deaths documented daily, but that's still a meaningful number. The presumed reasons for improvement, well, here we are just having gone through a summer and viral illnesses are seasonal by nature. I think there's an expectation that cases at least will go up again this winter. We have more effective vaccinations. I think that has improved both the documented case rate and clearly improved the documented death rate. We do, even compared to a year and a half ago, have modestly better treatments for those who do get sick. And I think it's not probably true that we have improved acceptance of social distancing. I think our efforts at social distancing have slipped a bit compared to May of 21. And I don't know how true it is that further improvement in the above metrics is broadly expected for now. What do we know specifically about COVID in lymphoma patients compared to a couple of years ago? Well, the severity of disease in lymphoma patients is unquestionably greater. There's longer length of stay in the hospital and higher mortality if hospitalized. Lymphoma patients who have recently been treated have worse outcomes if infected by COVID-19 than those that don't, particularly those who've been treated with either high intensity therapy or with cellular therapy, such as CAR T cells or stem cell transplants. We know that vaccination in lymphoma patients are safe. We know that there is some degree of helpfulness, but we're still uncertain if it's as helpful as in the general population. And thus, I would argue there is still some important consideration of social distancing, which affects, I know, many of your daily lives. So let's transition that into the rationale for telemedicine. Where did the telemedicine surge come from? By no means was it unique to lymphoma care. And I want to emphasize that the initial surge in telemedicine that we've appreciated the past couple of years was initially conceived not so much to protect immune-compromised patients from coming to the hospital. It was really meant because we felt a need to preserve nearly all hospital resources for this potential tsunami of COVID patients, both immune competent as well as immune compromised. We were concerned that our hospital resources were going to be overrun just taking care of COVID patients, so we needed to figure out ways to take care of our non-COVID patients in ways other than bringing them into our medical center. And only a secondary objective was to kind of maximize social distancing and a potential so-called cooties effect. You know, we don't want somebody coming in who's got COVID and infecting everybody else. And because of those needs, in March of 2020, so just 2.5 years ago, Medicare agreed to pay for telemedicine visits. And HIPAA regulations were, if not suspended, at least modified to allow for these so-called telemedicine or virtual medicine encounters. So those were two linchpins that were important in order for us even to be able to offer telemedicine to patients across our medical spectrum. Again, not just in the field of lymphoma. And indeed, there was a surge. These two figures demonstrate telehealth visits. So you can see in this top figure on the far left, we have February of 20, March of 20, virtually no appointments were through telehealth. And then in March of 20, they rapidly increased. And then they leveled off, stabilized a little bit throughout 2020. And then we had the winter of 21 again. And so they surged. And then they leveled off again a little bit. And then we had the next winter rising a little bit. But the point is that they've never, at least in this healthcare system, this is from a healthcare system in Duarte, but they've never really come back down. And so there remains a consistent offering of telehealth visits across that healthcare system. And this is from another healthcare system, this figure on the bottom, in which you look at the ratio of among telehealth visits, how many are done by video and how many are done by phone. And initially, there were a lot more done by phone until most healthcare systems came up with ways to incorporate video as part of the visit. And you can see now that a pretty steady, about half of all telehealth visits have a video component to them as well. Again, just emphasizing, this is nationwide, looking at telehealth visits that cross state lines. And again, you can see there were virtually none up until early 2020. And then came this initial surge, at least up through June of 20. You can see that we're nowhere back to approaching zero. This is a form of the practice of medicine that is invariably here to stay. This figure specifically depicts the issue of telehealth visits done out of state. And that's an important topic because various of us work in healthcare systems that variably interpret the legality of offering out of health or out of state visits. I happen to practice in a healthcare entity at the University of Iowa where we've been given very strict instructions that we're not to offer telehealth visits to patients who are at that moment physically outside our state lines. That's felt to represent a practice beyond the scope of our state license. Well, that's problematic for us and our patients who commonly like to spend their winters in either Arizona, Texas, or Florida. And for years, we didn't really think about it. We would often check in with them by phone and talk to them. And that was, we wouldn't necessarily bill for that, but that was considered a form of telemedicine. And now that the topic has exploded, we've gotten this directive that we're not to provide any medical advice to people not at that moment within our state. It's evolved a little bit into a don't ask, don't tell sometimes. Don't tell us where you are, and then we won't know. But this graph depicts the use of, from a patient's perspective, how often do they seek medical care, telehealth care outside of their state. And you can see that there's a big trend towards it's common for people who happen to live near a state border. They may be more accustomed to interacting with a healthcare system that just is on, closer to them, but on the other side of state lines. And then you've got the rural areas, largely depicted by Iowa and areas northwest of Iowa, in which they may not have very good access to an intra-state healthcare system nearby. And so the whole issue of out-of-state telehealth visits, I would submit, is a very important topic. There's obviously a market for it from patients' standpoint, and it's something that we haven't yet worked out as a system to be able to deliver very effectively. So I promised you I'd give some biases before we got into some data. There are a number of potential advantages to telemedicine. It absolutely can reduce time, reduce expense, reduce hassle of travel to appointments. Nobody likes coming to our parking lot at the University of Iowa, maneuvering the parking lot, and then paying the parking fee at the end of the visit. In addition, when we're doing telemedicine, we get the opportunity to learn about our patient's home environment, which even in the period of spring and summer of 2020, when all of my visits were by telemedicine for a few months, it really was informative at times to learn about patients' home environment. I learned more about patients in that scenario. I'm going to reach for a second. During one of my televisits with a patient, I said, "Boy, tell me a lot about that artwork on your wall there. It's really intriguing." And he pointed out that he did that artwork. It was something I hadn't known about the patient. I told him how much I liked it, and lo and behold, I became a proud owner of several pieces of that same type of artwork. So that was kind of fun, but it was a good message that, you know, there was something to be learned about patients in their home environment. The telehealth, the telemedicine, I think in many cases improves the likelihood that friends and loved ones are able to virtually attend. And that can be a very big factor for loved ones who otherwise would have to take off work or who lived in other states or counties and wanted to participate in the medical conversation and couldn't when the visits were only in person. In theory, it might be easier to network in other physicians involved in the care. So just as we might want to network in family members who live in other states, in theory, this would allow us to network in other physicians in other locations who are involved in the patient's care, such as a surgeon or the radiation oncologist as part of the same visit. It turns out that's challenging because they have busy schedules as well. There was a time when telehealth was important because we didn't have enough personal protective equipment to use for everybody. And so keeping people in their home environment reduced our need to use PPE. That's less significant now. There are, as we'll talk about, electronic systems, which may be better for monitoring symptoms than you trying to remember them and then loading them up once a month to discuss. It allows providers, it allows your physicians to be more available. There are times, right, when your regular appointment would be canceled because your physician was traveling. Now, at that moment, the physician may have not been actually in a meeting, but had traveled to a meeting, and this would allow physicians to potentially continue to hold virtual clinics during part of their professional travel time. And then many of you experience delays in your care when you're at the clinic because of bottlenecks related to exam room shortages, and that can be reduced by telemedicine by bringing fewer people on to campus at any given time. There are significant telemedicine potential disadvantages. I would argue there's the serious risk of potential shallower interpersonal interaction. I find the virtual environment is not as personal interacting as literally being in the same room together. There's a very clear inability to do a physical examination. There's less timeliness sometimes between the blood tests. I'm accustomed to a practice environment where the patient literally gets their blood drawn a half hour before I see them, so the results are very fresh. And then while I'm interacting with the patient, if something else comes up and we need to do a different test, it's available again immediately thereafter. I would argue that it's a lot easier for the physician to be distracted on a video visit. I have two screens here on my computer. I could have something going on the other screen, which is more distracting. And yet when I'm in the room with the patient, I find it easier to give my whole attention to the patient and their family at that point. Just as physicians can be distracted, so can the patients. Lots of things pop up on a screen at any given time or in a home environment, such as a dog, that can lead to distractions. And of course, there can be technical snafus, either related to equipment or internet service, inability for the physician or the patient to totally understand the system involved. And then there's either an potential increase, or at least a potential shift in healthcare disparities. We worry a lot about who all gets access to medical care. We recognize it's hard for patients in a rural environment to come to a medical appointment. And so we recognize that rural patients don't sometimes get the same care that our urban patients do. That can be ameliorated by the use of telehealth. But then on the other hand, not all patients that we provide care for have access to high-speed internet, have access to functional computers. And so we worry that we're leaving out patients in those categories. There are liability uncertainties, and I personally labeled this the Uber effect, right? When Uber first came about, there were questions about, well, does an Uber driver's car insurance really cover their liability if they're giving out rides on a for-hire basis, the same way that a taxi cab company's insurance would. And similarly, our malpractice liability insurance carriers are all starting to wonder now how our liability is affected if we're not actually seeing the patient and doing the full examination. So those issues have to be addressed. And then Medicare has pointed out there is substantial new avenues to provide billing fraud when we say we're providing virtual care. So there's a lot of issues that have to be addressed on the potential negative side as well. But let's use those potential advantages and disadvantages before coming up with any opinions to look at some of the data that's been collected over the past couple of years to say, well, what have we actually learned about telemedicine, telehealth? Patient satisfaction, obviously a hugely important factor. And it turns out that patients remained broadly satisfied. In one survey, 97.6% of patients were satisfied or at least very satisfied. 64% actually preferred telemedicine to in-person visits. And that was true across both surgical and non-surgical departments. And satisfaction generally improved throughout the course of 2020 as we came up with probably better systems for having these telemedicine visits. Turned out that smartphones and tablets resulted in higher satisfaction than desktop computers. Logging in ahead of the appointment, following a phone reminder, aided satisfaction. And as was true for in-person visits, one of the biggest contributors to dissatisfaction was long waits, logging in and then waiting for the doctor to log in. From a physician satisfaction standpoint, there was a little less satisfaction, but generally still somewhat. Surveys have suggested 75% of physicians in 2020 were satisfied, begrudgingly acknowledging that, it was better than no contact at all, which at the time was the option. There was some confusion or concern regarding licensing and the ability to practice across state lines, as I highlighted earlier. And it was clear that physician satisfaction was better by video than by telephone. Here is a survey that was published in early 2021, and this has to do with data at SLOAN Kettering. Now remember, SLOAN Kettering, a unique practice environment, very large cancer center, in which a lot of people historically would have had to travel a long way to attend their visit. And throughout these categories, to explain, 5 yellow represents 5, which is the best experience. And then the dark blue lines over here were the people who gave the worst scores. And then for each of these categories, telemedicine is on the bottom and an office visit was on top. And this represents practice in a radiation therapy office, or a radiation therapy practice, I should say. During the pre and intra-pandemic time, there were 350 televisits and 726 office visits. And you can see that in general, the experience overall was pretty similar between telemedicine and office visit. The friendliness of the physician was essentially the same, telemedicine and office visit. The explanations were almost identical. The concerns shown by the physician, again, the positivity was very high in both cases and virtually identical. The ease of scheduling the visit was virtually identical, and the likelihood of recommending the practice was virtually identical and very high in both cases. So again, that suggested a high level of satisfaction on the part of the patient. In this graph, as part of that same survey, green represents, well, the office visit was thought to be better. Blue represents telemedicine visit was thought to be better. And the coral color said, was the patient saying, well, no, it didn't really matter to me. And you can see the quality of the visit here, maybe a slight majority thought, or a plurality thought office was better than telemedicine. Some thought telemedicine was better. The personal connection, pretty strongly, most people said either no difference or office visit is better. Confidence that cancer will be treated appropriately, really no difference was the overall overwhelming majority. Confidence in physician, no difference, overall majority. You can see as you get toward the bottom here, the amount of time spent with the physician was slightly better with telemedicine than in office. And certainly the treatment-related costs, such as travel costs, lost wages, much better with telemedicine than in person. And the overall preferred visit type, people felt strongly. Very few people felt there was no difference. A little bit more said, I'd rather do telemedicine, but there were still some, 30% of people who said, oh no, I think the office's visit. So people had strong opinions, but they were on both sides of the fence. One of the other ways of measuring quality is not just patient satisfaction, but in the primary care field, Medicare has long measured quality in part by how many people with diabetes got their hemoglobin A1C checked, and how many people who were age appropriate got colonoscopy screening or mammography, how many people age appropriate got their cholesterol checked. So very objective measures of how healthcare was delivered. And this was a paper published in which once the pandemic started, so almost a 2-year period from March of 20 to November of 21, there were about 500,000 patients with primary care visits. And so this was pretty big data. 400,000 with office visits, 117,000 with telemedicine visits, and they were evaluated for 16 quality measures in 5 areas of primary care. And I'm not going to bother you with all the details of what those domains were. I gave several examples at the beginning of the slide. But the reality was the delivery of these primary care quality measures was identical between telemedicine visits and office visits. And it suggested, at least in the primary care setting, patients could be confident that they would get the same measures of quality in primary care from telehealth as they could in office visits, given this 2-year time frame. This slide's a little busy. It goes into a little bit of details in a slightly different studied case, but it had to do with the question of, this was done at the Mayo Clinic, and it was really a pretty clever study design. They said, well, after a telemedicine visit, in many cases, the physician had to say, well, I think the patient is suffering from X or Y or Z based on these symptoms. And then they came in for follow-up and had an in-person visit in which they said, now I think the patient had X or Y or Z. And the purpose was to see, well, how often were the physicians, quote, right in the telehealth visit if the office visit was deemed to be the gold standard. And these numbers, I think, are interesting. For adults, the answer was 87% of the time they were right. On the surface, that strikes me as a pretty good number. It's not 100%, but it's not a bad number. A little less often with pediatric patients, 78%, and no different between men and women, both about 87%. And so you say, well, is 87% good enough? It's not bad, but is it good enough? That's a judgment, I think, right? Everybody can make their own judgment. The good news for people on this phone call is they broke it down by specialty. So the groups at the top had the highest degree of accuracy, and the groups at the bottom had the lowest degree of accuracy. And right at the very top, radiation oncology, hematology oncology. So that's good news, is that our specialty tended to have the highest concordance. That is, after they came in, they had the same opinion a high percentage of the time as they did when they evaluated the system over the phone. And you can see that again, for issues related to neoplasms, for issues related to mental health, mental behavior, that's where the highest area of accuracy was. They struggled most with skin-related diagnoses, diagnoses related to the genitourinary system, and explanation of abnormal lab findings. And I think it's fair to say that in general, over the course of the 2 years, it's been very clear that psychiatry is a practice that has, in many ways, benefited substantially from the involvement of telehealth. And I think that I personally know a number of psychiatrists whose practice is still predominantly telehealth, and they and their patients find that to be superior to coming into the office. Endocrinology apparently has been recognized as a practice that does well with telehealth. Oncology is somewhere in the middle. At the far end of the spectrum, ophthalmologists and orthopedic practices have generally, at this point, concluded they've not figured out a way to deliver telehealth very effectively. So it varies from practice to practice. And I submit that telemedicine, as we know it here in late 2022, works pretty well in some situations. Probably not quite as well for sick people as for preventative health scenarios. It's very clear that telemedicine is loved by some and hated by others. It's also pretty clear that telemedicine, even as we know it, is probably here to stay in some hybrid form. There'll be some in-person visits as part of your care and some telehealth visits as part of your care. But I think the key here is as we know it. And what I learned as I prepared for this presentation was we really need to tip our cap to those who are creative in saying, okay, if telehealth is here to stay, how can we really make it a positive? So I want to introduce you to this study, which I found to be fascinating. It's called a real-time remote symptom monitoring during chemotherapy for cancer, the European eSMART trial. Okay, so in this trial, they took several hundred patients who were undergoing chemotherapy for either breast cancer, lymphoma. There was one other cancer type as well. But the notion was they were about to get 4 months or 4 to 6 months of chemotherapy. And they were instructed on a handheld device at home on a daily basis to fill in a number of questions. Do you have this symptom? Do you have this symptom? Do you have this symptom? Are you having trouble with this symptom? And they would record their temperature digitally. On a daily basis, they would fill out these questions. That information then would go into the cloud, and the physician at the clinical site would receive an alert every day based on these symptoms. And we'll go into detail in a minute, but then the alert on a daily basis would either challenge the physician to say no action is needed or to respond in some way to the patient. Okay, now there were amber alerts and there were red alerts. And the amber alert was, well, the physician needed to acknowledge the alert, but it wasn't something that was terribly serious. The target time had to be, the physician had to respond within an hour, and the response could be, understood, I get it. And there was also an algorithm by which if patients said, I'm having trouble with nausea, they would get an automated response to say, remember, here are the best approaches to nausea. And so sometimes the physician would simply acknowledge within 8 hours and say, yep, our automatic response is good enough for this patient. A red alert, which would be something like patients having fever, patients having pain, yesterday they had nausea and today it's worse. Those were considered red alerts. The target time for response was within 30 minutes and often involved literally a personal interaction with the patient. There were about 400 patients in the system. And remember, they were going through chemotherapy for a course of 6 months. So there were 3,500 red alerts generated, 3,700 amber alerts generated. And overall, about 90% of the time, indeed, the clinician responded to the alert within this target time of 8 hours for amber or 30 minutes for a red alert. So pretty good response time. And then every day, the patient's symptoms were measured. And this is symptom severity. And I should mention that there were 400 patients that were assigned to this monitoring system and another 400 patients that were assigned to the usual care, where you come in every 3 weeks and you say, here's what's been going on for the past 3 weeks, and the patient and the clinician reacts with infrequent calls in between. And you can see that the usual care over the course of those 6 cycles in general had more symptom severity than patients who use this daily e-monitor system. And that's a meaningful amount. So whether it can be scaled, remains to be seen yet. But I think it was really informative that they took a creative form of telehealth, as opposed to just saying, well, I've got my 30-minute appointment and it's on Zoom instead of in person. They're really using the full potential of the telesystem, if you will, to automate symptom monitoring. And at least in this experiment, they really reduced overall symptom severity significantly with aggressive use of an automated telehealth system. So I think my final comments would be that the rationale for telemedicine here now in 2022, it's very clear that telemedicine is neither going to go away, nor will ever fully replace office visits. We're no longer afraid to have you come and see us. We have plenty of capacity in our hospital, and we're not afraid of cooties. Telemedicine, in my personal opinion, is a great choice when talking is all you need, and you don't need a physical examination or administration of therapy. It avoids travel. It allows loved ones to join via conferencing without missing work. It still optimizes social distancing for our immunocompromised patients. But this forces us to evaluate, when is talking enough? And I think the last experiment that I just described to you is one example of that. Physician engagement and satisfaction needs to be addressed, as well as patient engagement and satisfaction. It's likely to be quite variable, in part upon the dependency of the practice upon travel. Some of our tertiary large medical centers that draw from patients all over the country are going to be more inclined to offer telehealth. Those practices in which most of their patients come from a local area are going to be less dependent upon developing ways to deliver telemedicine. Insurance coverage, licensure laws will ultimately have a lot to say about this option as well.